Okay, good evening, everyone. Sorry to keep you waiting. Had to finish my OPD in a rush before getting back to this. So last time we were supposed to do something different. We thought of going into sarcoidosis, but then people thought we hadn't covered vasculitis mimics. So I thought I'll take this up rather than giving it to one of you. So originally I thought I'll do something called vasculitis mimics an unusual vasculitides. That is very unusual or rare case of vasculitides. But then when I prepared the presentation, I thought it's going to be too much to take on. I think vasculitis mimic itself is going to pull us through an hour. So that's why I've restricted my discussion to vasculitis mimics only for today. The format is that I'm going to do some case presentations. I think I have about 6 or 7 cases just to get you a flair, because you've heard enough theory in the last 2-3 weeks of vasculitis, whatever we did. So I thought I'll go by case-based discussion. Some of you are leaving out Tanmay and Ravi because they've seen some of these cases. Some of the other residents can actually unmute yourself so that when I throw a question, you could just quickly give a 1 or 2 line answer. We'll see how it goes, and let's try to keep it as interactive as possible so that it will be interesting on both sides. So the first case is a 79-year-old male who actually presented with arthralgia, myalgia, and rash on his legs of 3 months duration. He also felt feverish and had weight loss of about 4 kilos. Otherwise, he was a fit and well male. The only past medical history of relevance was a history of carcinoma colon, which had been declared clear after his surgery, and he would have routine annual colonoscopies. And this was a case that I picked up in UK while I was there. That's why you will see this annual colonoscopy business. Otherwise, here people don't do it as much. And clinically, when we saw him, because of his rash, he was referred. There were splinter hemorrhages in his nail beds, and he had a rash on his legs. I'll show you how the rash looked, and that's how it is. So for those of us who are now have learnt about vasculitis, we don't have any doubt that this is a vasculitic rash. So he has vasculitis, he has arthralgia, malaise, some fever, weight loss. So investigations. His inflammatory markers were raised. He had mild normocytic anemia. He had microscopic hematuria and very mild proteinuria. Chest X-ray was normal. ANA was negative. ANCA, C ANCA was positive with a moderately raised PR3 titer. Cryoglobulins, hepatitis serology, rheumatoid factor, complements, whatever you want, all those things were negative. So obviously, now the question comes, last time we were talking about histological confirmation of where to get a diagnosis, where to get a tissue diagnosis from. So by the time we saw him, he had already had a skin biopsy when he first had the rash, which had shown leukocytoclastic vasculitis. So any of the residents want to take a call? What do you want to do next? One next step?
Renal biopsy, sir.
Okay, so some sensible thing would be to do a renal biopsy because you see microscopic hematuria. Okay, so I'll tell you what I did. The presentation. But basically, what we were trying to do is, because of the splinter hemorrhages and the microscopic hematuria, the first thing I did was an echo. The echo actually showed that, this is actually a good echo, a beautiful echo. Actually, I would have loved to show you the echo, but unfortunately, it's not playing up for some reason. Let me see if I can click on this, whether it makes any difference. Okay, so that's okay. Let's not waste time. So basically what it shows is this is actually a large vegetation. What you see here is a large vegetation. So maybe at the end of the presentation, if I'm still able to play this echo, I'll show you. That's a very large vegetation. And basically what he had was endocarditis. And once we saw the vegetation, we sent blood cultures, and the blood cultures grew enterococcus. And he was treated with benzyl penicillin and gentamicin for 6 weeks. And he was well. He gained his weight, rash disappeared. And a repeat echo 4 weeks later just showed a minute speck on the mitral valve. And he had a moderate to severe MR because of a little bit of damage to the mitral valve leaflet. So basically, how did he get this enterococcal endocarditis? Now in UK, as I told you, they have this annual colonoscopy ritual. And he had undergone a colonoscopy about 4 months prior to this presentation. And when he had that, he had a polyp, a large polyp, and he had undergone a polypectomy. So this was the source of heterogeneous spread of infection from the bowel causing endocarditis. So what made me suspect endocarditis in this patient? As somebody rightly said, a renal biopsy. Now, when you see somebody with endocarditis, with this presentation, the red herrings in this case for me is one, weight loss. Although weight loss can be there in vasculitis, fever can be there in vasculitis, microscopic hematuria, and splinter hemorrhages. So when you see this combo, always look for, there was not much of proteinuria at all. It was mainly microscopic hematuria. Always exclude infection before you go to the next, because there was not much of proteinuria. Ideally, if I had seen nothing on the echo and cultures were negative, my next step would definitely be a renal biopsy. So that was the red herring, and that is how we bumped up on this case of endocarditis, which is a treatable condition. And the lesson you learn out of this case is ANCA positivity. ANCA can be positive in infective endocarditis. That's the lesson. And we'll discuss about this a bit more later. So this takes me to the next case, which is a 35-year-old lady who came with an 8-month history of left hemicranial and hemifacial pain. She also had a proptosis of the left eye with complete paralysis of extraocular movements. So that's her photograph, fairly visible for you. That's the left eye proptosis. And we've asked her to medially look, and you can see that the eyeball is virtually frozen here. So there is complete loss of absence of extraocular movements, and there is a fairly significant proptosis. So when you see proptosis like this, obviously the first thing that happens is they go to the ophthalmologist. They don't come to us directly. And rightly so, the ophthalmologist did a CT scan. And you can see that on the CT scan, you have a retroorbital tumor. You can see a retroorbital mass on the left side. Okay. And the sinuses are also filled. So when you see a retroorbital mass like this, obviously they need a biopsy. So the ophthalmologist took up a biopsy, and this is the histopathology slide of the same biopsy. And the biopsy showed a small thrombosed part. The blood vessel showed thrombosis, disruption of the internal elastic lamina, and dense inflammatory infiltrate. And this histological appearance is consistent with a diagnosis of vasculitis. So that is when she was referred to me. And when I saw her, she had no other features of systemic vasculitis. She had only this isolated proptosis, just a moderately raised ESR. Her blood parameters were normal. Chest X-ray was normal. ANCA was positive, but the PR3 titers were negative. Then I had the biopsy rechecked by the pathologist. I called up the pathologist and I said, see, whenever you find a mass, always look for other things. Infection has to be excluded. So an acid-fast bacilli stain, fungal stain, everything were done, and they were all given as negative. So obviously this was localized or limited vasculitis. So my plan was, obviously, while waiting for the final biopsy report to start treatment, 2 days later, the family reported that the lady had developed right hemiplegia, facial weakness, and expressive dysphasia. They had already spent enough money on the investigation, so I couldn't get an MR. I did a CT brain, which showed an infarct in the posterior limb of internal capsule. So what do you do next? Who wants to take this? Anyone? No takers. Okay. So when you get this, things like this, one has to be always careful. One of the important lessons I learned from this case is, as much as clinicians haven't seen vasculitis, pathologists have also not seen vasculitis. So when I had a doubt on this presentation, what I did was I sent the same biopsy material to another lab, to another good pathologist whom I believed more, and I asked them to have a look. And they sent me these beautiful pictures. Anybody wants to take a guess? What does this histological picture show? So basically, what this shows is a multinucleated giant cell. So the big arrow here shows multiple nuclei. This is a multinucleated giant cell. And the yellow arrow, you see a longitudinal structure like this. And the longitudinal structure, what you see are in plenty on this biopsy specimen. In other fields as well, I've pointed out all the arrows, and these are actually fungal hyphae. Fungal hyphae. So basically and we sent the specimen for culture immediately, and it grew aspergillus. So basically this was a rhino orbitocerebral aspergillosis. I don't know why she got it. She's from rural North Karnataka. So anything to do with her occupation, I don't know. She was HIV negative. She was not immunocompromised. She was not a diabetic, and she was started on an IV amphotericin B. But unfortunately, she succumbed on day 7. So what made me think that this is not a straightforward vasculitis? 2 points. One is that the anchor was not strongly positive. Okay. But then, yes, you can always argue that limited vasculitis, when it affects the eye, for example, only a retroorbital tumor, can be anchor negative in nearly 60 to 70% of the cases. But actually, I had taken the CT scan for the discussions. And what we actually saw on the CT scan, in addition to the proptosis that you saw on the left side, I told you that the sinuses were full. The appearance on the CT scan of the sinus on the right and the left side was different. On the side of proptosis, the sinus was filled with a mass-like structure rather than with the mucus that you normally see on that side. So generally in chronic sinusitis, you only see mucus or mucosal thickening in the sinuses, which is what you would expect to see in Wegener's or GPA, whereas in this case, it was more a mass. Now, generally, it is unusual to get a sinus mass or a mass in the sinuses in vasculitis. So, and then we went and we had a further look at the CT, and the mass was extending right into the orbit through the apex of the orbit. So that is why I thought this did not look straightforward like vasculitis, even though there was nothing else to contribute. And the histopathology, the first report, was consistent with vasculitis. Now, it is important to understand that aspergillus is an angio-invasive fungus. So you can get vasculitis due to the fungal infection itself. So the first pathologist was not wrong. He was correct that there was vasculitis, but where he went wrong was he missed out on the fungal hyphae completely. So that is where he went wrong. So which the second pathologist was able to. That's why clinical history examination is very important when you look at vasculitis, and you have to keep thinking this again and again to say, am I looking at vasculitis or is this something else? So that's the lesson you learn. And also beware of positive anchors. And I showed you in this case also there was some mild anchor positivity. So we would have, if we had not done a PR3, would have easily jumped based on that to make a diagnosis of vasculitis. And had I given her steroids, and cyclophosphamide, which is what was my original idea before finding aspergillus, she would have died not on day 7, but on day 2. So this brings me to the third case. This is a 48-year-old male, a fit and well man, a farmer by occupation, who was referred to me from Tumkur, who presented with recurrent nasal obstruction and crusting of 2-month duration. He also had sinus pain, both frontal and frontal, as well as maxillary and occipital headache. Otherwise, He had no other systemic symptoms. Because of his nasal obstruction and crusting, he had gone to an ENT surgeon in Tumkur who noticed that he had severe nasal mucosal thickening and sinus tenderness. So his routine investigations were normal. Viral serology was negative. Creatinine was 1.2. An ultrasound abdomen was done there. It was normal. I don't know why it was done, but that was it. This was the CT scan report of the paranasal sinuses. If you see, there is not much to actually see on this, except that it is all suggestive of chronic sinusitis. And there's hardly anything to see on CT scan. There's no destruction. There's no mass-like lesion, nothing. So the ENT doctor did a nasal biopsy, which was labeled as non-specific inflammation. He was given some symptomatic treatment. There was absolutely no relief. And the biopsy specimens slide was sent to Bangalore for a second opinion by the doctors from Tumkur, which they did the right thing to do. And that was the biopsy specimen. Now, that is a very difficult biopsy to comment. I've not deliberately put a bad part of the slide. This is how the biopsy looked actually. And what you actually see in the biopsy is large artifacts. And that is because this is a crushed specimen. While we were talking about biopsies in the last class, I was telling you guys about not to take a biopsy from the nose with the forceps. You have to go for a nasal endoscopy and then a biopsy. So when they took a biopsy here, this was a complete crushed specimen. And what was left of it obviously showed only some non-specific inflammation. And then obviously the pathologist there said much crush artifact noted. You see that there. But also seen entrapped within this is medium-sized thickened and sclerosed blood vessels, negative for acid base bacilli and fungi, but possibilities to be included are Wegener's and mycobacterial infection. That is where the danger comes. Once you give this diagnosis to people, people start imagination or they start treatment. So ANCA and ANA were sent, both were negative. So this was diagnosed as a granulomatous inflammatory disease of the nose, and the patient was started on 60 milligrams of prednisolone by the treating doctor in the native place. So obviously steroids are known to improve a lot of things, and they did feel better. The patient did feel better for some time, but afterwards he kept complaining of the same thing again and again. And that is when, he had almost received 60 milligrams daily for almost a month. And that is when he was referred to me for a second opinion. So when I saw this patient, there was no other symptoms of systemic vasculitis. He had persistent severe nasal symptoms. See, the symptoms were completely out of proportion to the headache, to what you see. And clinically, there was hardly anything. I did a CBC urine. They were all normal. There was no renal thing. I repeated the creatinine. I've not put it here. And the creatinine was normal. Initially, it was 1.2. So what do you do when you are faced with this situation? There are some odd points. What makes me think that this may not be vasculitis? One, ENT vasculitis on clinical examination showing only mucosal thickening. Why would he bloody not respond to steroids? And that was 60 milligrams of steroids. You've already given him 60 milligrams for a month. By now, if this was Wegener's, it would have melted completely. So the very fact that it did not melt, in fact, was only getting worse with time, means that this is something else and not Wegener's. So that's when I asked for a repeat biopsy. So I called up my good friend, Dr. Munishwar in Tumkur, who does nasal endoscopy. And I told him to take a nasal endoscopic biopsy and not a forceps biopsy. Now you can see the difference in the two slides that I showed you. This is the second biopsy specimen. And what do you see in the second biopsy? There is dense lymphocytic infiltrate, dense, very dense. The whole slide is filled with lymphocytes. The blood vessels are all surrounded by lymphocytes. What is unusual for this in vasculitis? You don't get a lymphocytic infiltration. Even if you did see some blood vessel infiltration, it is predominantly going to be neutrophilic and not such dense lymphocytic. So what I did was, so obviously what it shows is dense aggregates of lymphoid cells. I've told you all this. Numerous thick-walled blood vessels and infiltration of lymphoid cells into the walls of these vessels. So I asked them to do an immunohistochemistry, and an immunohistochemistry on the specimen was positive for CD3, consistent with a T cell lymphoma. So the final diagnosis in this case was a nasopharyngeal lymphoma. Now, why would this become a vasculitic mimic? For two reasons. One, patients can present with symptoms that mimic vasculitis. And in this case, it was nasal crusting and nasal obstruction and chronic sinusitis, which can be symptoms that you see in patients with GPA. And also, the pathologist had raised the question as to whether this was vasculitis. And that's why this becomes a vasculitic mimic. So just to say that lymphoma can be a vasculitic mimic. So next comes case 4. This is a 40-year-old male who came with a bluish discoloration of his fingertips, extremely painful. His past medical history: 1, he was a hypertensive for the last few years. 2, he had had a road traffic accident 2 years ago when he sustained a left kidney trauma, and he had enlarged left kidney with severe hydronephrosis, hydroureter, and a poorly functioning kidney for the last 2 years. So one kidney was gone, and his creatinine was 1.2, and he had the same creatinine for the last 1 year. And he had taken urologist opinion, and they had said, since it's a damaged kidney and it's not causing him any problem, to well leave it alone and don't interfere. So what brought him to the hospital was recent hematuria. So he presented to the urology department at Fortis and Shankara, two urology departments with recent onset hematuria. And the doctors did a CT scan kidney along with hydronephrosis and hydroureter, and they also did a left renal angio and could identify some bleeding spots, so they embolized it and the hematuria stopped. But the urine examination obviously had shown a lot of blood at that point in time. So they advised conservative management and nephrectomy as required. So on this story of the background, he presented again with bluish discoloration of his fingertips. So I should thank Dr. Srinivas, rheumatologist from Fortis, who gave me these slides, because he referred this patient to me for another opinion, and I'll tell you why. And what you see on the fingertips, you can make out these vascular lesions, okay, or vasculitic lesions. And this is more evident. This is like a pernio type of lesion. They're called pernio type of lesion, which you very classically see in vasculitis. You see it more in small vessel vasculitis. You also see it in polyarteritis nodosa. So that is a vasculitic lesion without doubt. And you can see one also here in the nail bed. So these are pernio-like lesions. So he had a blood test done. His anchor was negative, ANA was negative, complements, chest X-ray, rest of the times things, cultures were all negative. A CT KUB was repeated, and it was compared with the previous CT, and a report was given that the enlarged kidney appearance was much similar to what was seen in April 2017. Incidentally, he had developed some granular lesions over the tongue, which was biopsied. They suggested there were some granulomas, and somebody had given him some course of steroids. By then, those granular lesions had disappeared. So you have some vasculitic lesions, and you have on story some granulomatous lesions. So this is when a diagnosis of vasculitis was contemplated. Over the next 1 week, he developed severe pain and swelling in the wrist and the elbow, the left wrist and the left elbow. So arthritis is also well known in vasculitis, no surprise here. But then when he was referred to me, this was not a plain arthritis. In fact, this was more a firm periarticular, extremely tender swelling around the left lateral epicondyle and the left wrist on the flexor aspect. So these were completely different. This was not arthritis. This was real lump. And I could also see a few painful nodular lesions, especially at the index fingertip. We did a nail fold infarcts and vasculitic lesions had by then reduced in intensity as he had been on some small dose of steroid. So the first thing was to see whether this was an abscess. So we did an ultrasound scan, and the ultrasound scan showed only solid lesions, and no, it was not an abscess. So the next thing was to image it better. So we did an MRI. The MRI shows a solid lesion which is abutting the musculature here, and also another solid lesion here in the subcutaneous facial planes right close up to the muscular planes. And it is more evident on this view. You can see this well within the muscles. Okay, that's a large soft tissue lesion in the elbow. So when I saw these vasculitic lesions and these unusual lesions, I sent him for an echo. So when I saw the echo, we were equally surprised. The picture courtesy is from Dr. Sunil Dwivedi, cardiologist at Vikram. And the echo shows that there is a large sessile mass that is abutting the apical part and the septal part of the left ventricular cavity. And more also, a similar mass is seen abutting the right atrium. Okay, so you have two mass lesions in the heart, you have two solid lesions in the forearm, you have vasculitic lesions in the fingers, what else? And some granulomatous lesions on the tongue. So obviously we need a histopathology. And what we did was to biopsy one of these. We did an ultrasound guided biopsy of one of these mass lesions. And the mass lesion showed pleomorphic cells with abundant eosinophilic cytoplasm with very large vesicles and prominent nucleoli, and they were in lobules. And that is a histopathology specimen processed at Vikram and courtesy Dr. Pratimar, pathologist. So we did an immunohistochemistry on this, and that's the immunohistochemistry, which was positive for something called PAX8 and CD10. So CD10 and PAX8 were the two important things that were positive. So what do these two suggest? These are both specific markers for renal cell carcinoma. So we were shocked because he had come through two urology teams to a rheumatologist for a tiny finger lesion. And then again, we had to revisit the CT scan and send it to another radiologist. And then the radiologist opined that it was not that the kidney was big, the native kidney had completely shrunk. And what everybody was commenting as a large kidney or a deformed kidney was a 10 centimeter by 10 centimeter exophytic mass. So this mass was completely missed by two radiologists, two urology teams, and finally this turned out to be a case of metastatic renal cell carcinoma, which had metastasized to the muscle as well as to the heart, and vasculitis, especially cutaneous vasculitis, and whatever those granulomatous lesions in the tongue were only a paraneoplastic manifestation in this patient. So this was the final diagnosis. It was a metastatic high-grade renal cell carcinoma, and just to recapitulate how his fingers looked at the time of presentation. Case 5. So this is a 43-year-old lady who presented with polyarthralgia of 4 months duration. All her routine investigations were normal. Her rheumatoid factor was 59. Her CCP and ANA were negative. So she had gone to KMC Manipal, and the medicine department saw her rheumatoid factor, and they put her on methotrexate and hydroxychloroquine. Rightly so, because she had nothing else. But then that gave her obviously some symptomatic relief. Now the next presentation of hers was this, and thanks to Dr. Deepak from Shimoga, who took these beautiful pictures when he sent this patient to me for a second opinion. That is when I saw this patient. And what you see are black lesions here, okay, black lesions which look like ischemic lesions. And obviously there are some other lesions that looks like an infection. There's some pus there, there's some ulceration there, okay. So this was the presentation. And you can see the fingertips here. and the hands. So, in addition, when I examined this lady, she had symmetric sensory neuropathy of both hands up to the wrists and both legs up to the ankles. She had various investigations done outside, and the urine protein was negative. ANCA and anticardiolipin were negative, but her lupus anticoagulant was positive. Keep a note, that's very important. And viral serology was negative. So what made me think otherwise? If I go back on to these lesions, on the first appearance, this might look gangrene, but this is not. If you actually look at it, there are multiple wounds in this person. And if you look at the hand, let me go to this. Yeah. Why would you get wounds in these places in vasculitis? And these are not vasculitic wounds. If you see these are not vasculitic wounds. So then I thought that these were more of burns. These were more of burns. The patient is a lady who's cooking regularly. She had no sensation in both her hands due to neuropathy. And these were actually burns. And this was more a burn eschar rather than a digital gangrene. And one other clue is this, I would call it almost like paradigital. This is not at the tip of the digit. It is in a very odd place. And if you look at it, this is the place where people hold the vessel. So in vasculitis, you will see a lot of changes at the tips. You don't see it in these unusual locations. So that's why I thought, even though the lupus anticoagulant was positive, I didn't entertain a diagnosis of connective tissue disease or vasculitis. So when I examined this lady, I palpated her nerves. So ulnar and common peroneal nerves were thickened, although I could not find any hypopigmented macules or other features of Hansen's. So what we did, she had a skin biopsy there. So we asked them to bring the skin biopsy slides. We didn't repeat a biopsy, and I gave it to Dr. Pratima at Vikram to have a relook. So what does the skin biopsy show? The skin biopsy shows that the epidermis shows hyperkeratosis, irregular acanthosis. The dermis and subcutaneous tissue show multiple epithelioid granulomas. So that is a large epithelioid granuloma. And that's the nerve you can see, nerve sheath. It's a sort of perifascicular granuloma. And here you can see that is the skin retace, subcutaneous area, and you can see multiple granulomas. She's put an arrow there, and multiple granulomas in the deeper tissues. So you had multiple granulomas, no necrosis whatsoever. There was no fibrinoid necrosis. The blood vessels were not affected. And we asked her, because of the thicker nerves, to also do a modified Zeden stain, and lepra bacilli was negative. So what is the diagnosis? Any clue? Anybody? Any of the residents who are sleeping? Anybody wants to take a shot at this?
Is it still Hansen's though?
Why would you think so?
Because in the purely neurotic type, you may not get bacilli in the histopathology.
Fantastic. Who is that? I sorry, I can't see your names. I'm just in a slide.
Sir, this is Anu. This is Anu from UK.
Oh, Anu, hi. nice to hear your voice. Okay.
So I'm actually sitting. I knew your talk was on, so I'm hiding in one of the clinic rooms.
That's nice to hear from you. Yes. So modified Zine-Lesion stain can be negative, or lepra bacilli can be negative in borderline Hansen's and pure tuberculoid Hansen's, TT and BT Hansen's. So this was purely a case of Hansen's. So that's why I put these lesions again, which were actually burns, and they were not vasculitis. This was burn eschars, and this was a classical case of Hansen's, which was referred as vasculitis. And we referred the patient back to Shumaga to the physician to treat Hansen's, and I got a feedback from Deepak later on that she's doing very well. So I think this may be the last, or maybe one more. Let me see. 59-year-old male with no comorbid illness who was admitted with fever with chills of 3 days, burning micturition of 3 days, and a bilateral symmetrical black discoloration of all parts of the body almost, which rapidly progressed within 3 days. So this was his initial presentation, and he presented to Dr. Vinita Shobha's OPD in St. John's with this presentation. And these pictures, I should thank Dr. Vinita Shobha because she had taken these at that time, because that was his first presentation. And you can see symmetrical gangrene, almost every digit being affected. You can see his ear. You can see that, the nose, and the fingers. So this is almost like diffuse, symmetrical, bilateral gangrene. So investigations were done, which showed a normal hemoglobin and a total count, but his platelet count was 25,000. The peripheral blood smear showed normochromic anemia with thrombocytopenia and fragmented RBCs. His other investigations were all normal. ANA, ANCA, APLA, cryoglobulins, complement, viral serology, name it. Dr. Vinita obviously would have done everything. So everything was normal or negative. His coagulation profile was slightly deranged. The D-dimer was slightly up, could be due to infection, but the INR was high. There was fragmented RBCs, and also, in addition to the fragmented RBCs, there was thrombocytopenia. So put all this together, obviously these would suggest that there was a mild DIC going on. And the urine examination showed plenty of WBCs with bacteria, and the urine culture showed E. coli, and E. coli in significant growth, and ultrasound showed cystitis. So basically, this was a case of septicemia, E. coli septicemia, which presented as gangrene. So he was treated with antibiotics, some steroids, and heparin, and he was afebrile after 2 days. The platelet count and coagulation profile improved after 5 days. So this was when he was discharged from St. John's, and somebody referred him to me, again saying, is this vasculitis? Have they missed something in St. John's? Very less likely that they would have missed anything, but it's important to understand that infection can present as vasculitis. So he was under my follow-up later on, up to about 6 months, and you can see his feet. This was his feet after about this was about, I think, 2 months, and this was about 4 months. All the superficial gangrene that he had dropped off. And that was his face. That was the initial presentation. That was 2 months later, and this was 6 months later. And that was his hands. Okay, so, and I mean, since then, I've seen a few viral also, post-viral, such gangrene. I've seen such gangrene in the setting of ICU when people come with hypovolemic shock. So it's not unusual to see this sort of an acute gangrene. So what rules out vasculitis in this? Why can we not think of conventional? This is vasculitis, but not, why do we not think of a primary systemic vasculitis? That is with the rapidity with which it has happened, and there's a definite etiological cause here. And generally in vasculitis, you don't get this enormous peripheral gangrene of this magnitude. So what did I use to treat? No treatment. Spontaneously kept all the wounds clean. He was given a short course of steroids just to arrest the progression of the inflammation at that stage. But afterwards, I stopped everything and just kept him on follow-up. A lot of these superficial gangrenes dropped off, and you can see quite a bit of his digits were salvaged. So I did nothing other than reassuring him Dr. Vinita had already done everything. So that brings me to the last part of my talk. So what are vasculitic mimics? So I've shown you a wide variety of cases here. And when we see patients, some are symptom mimics. That is, they have symptoms that mimic vasculitis. It could be nasal symptoms. It could be eye, like proptosis I showed. It could be neuropathy, like the lady I showed. And in that Hansen's patient, one of the other unusual things about neuropathy, it was a symmetrical neuropathy. Whereas in GPA and other conditions, it's more of mononeuritis multiplex. But then you can get Sjogren's and vasculitis and symmetrical neuropathy. But I'm just for discussion's sake. Then you can get sign mimics. So there are vasculitic signs that are mimics. So rash is the commonest, but I've also shown you other signs like proptosis, nasal masses, so on and so forth. Then investigation mimics. So there can be, and one of the biggest mimics is ANCA. ANCA can be false positive in a variety of conditions. So you can have ANCA mimics, what we saw. And then there can be biopsy mimics. There can be certain places in the biopsy which might demonstrate vasculitis, but it's up to you to give all the clinical information required to the pathologist so that they look more and they keep on looking for, and you tell them this is what I think is clinically the case. And I asked them to say, so when I gave the last case, the Hansen's one, to the pathologist, I said, I don't find anything, but I find thickened nerves and these things which I don't think is vasculitis. Even though lupus anticoagulant is positive, I don't think this is vasculitis. So have a look for something unusual. So when you say this, obviously the pathologist knows, otherwise you'll get these routine reports. They say suggestive of vasculitis for better clinical evaluation, and the ball is back in your court. So biopsy mimics are common. And then finally, internet mimics. It's not unusual for people to put all their photographs in on the net and come out of Google and come with variety of diagnosis and say, and I had actually one patient who self-referred himself as vasculitis. Although vasculitis is a rare disease, actually he was correct, it was vasculitis. In fact, I was initially doubting it. He turned out to be one of my polyarthritis nodosa patients later on. So many infections can mimic vasculitis. Endocarditis is the commonest. You have all sorts of sepsis. You know, meningococcal sepsis in children can have vasculitic rash, necrotic purpurae. TB can produce vasculitis. Fungal, I've already shown you. Hepatitis B and C, you know, PAN and cryoglobulin mimic vasculitis. HIV is a great mimic of anything and everything. And of late, obviously, the latest one to come into this is COVID-19, which is also a vasculitic mimic. So I thought, let me pull out some quick literature. This was what I was doing at 4:58 when you were all waiting. I just wanted to get some literature at least. If you all remember, recently, Dr. Vijay Rao had posted some pictures of COVID-19 and vasculitis in IRA Karnataka group. And those pictures were very similar to the old man with the UTI who had the necrotic nose and the necrotic ears. So one of the largest series reported from Spain, which had 375 patients with COVID-19, although most common lesions were the usual viral maculopapular, a pernio-like lesion, what I showed you, the fingertip blues, were seen in almost 19% of the patients. Livido or necrosis was seen in 6% of the patients. That's quite big. Out of 100, you see it in 6 patients. That's quite big. And then thrombotic occlusive vasculopathy and cutaneous vasculitis was described. And more so now, there has been a lot of description of Kawasaki-like illness in children, that is medium vessel vasculitis in children with COVID. There are 2 series that reported it. The French series reported a higher proportion of GI symptoms and shock-like syndrome, and the Italian series reported more cardiac involvement and macrophage activation syndrome. So, you know, this is some quick info that I got from COVID. I didn't want to download pics from the internet because it doesn't look any different than what I have shown you till now. And those of you who saw the recent pictures posted by Vijay Rao would remember. Then, as I told you, malignancy, always one of the other reasons when you see embolic vasculitis is left atrial myxoma. Left atrial myxoma can present with cutaneous vasculitis. So that's another reason why you do an echo. But various malignancies like lymphoma, I showed you nasal lymphoma, leukemias, MDS. Right now we have a patient. We are working him up with bad cutaneous ulcers and working him up for MDS because he's got some abnormality in the blood, peripheral smear and blood counts. So they can all mimic vasculitis. And I have also shown you solid organ malignancy like renal cell carcinoma. Now, drugs can cause vasculitis, particularly cocaine sniffing can cause like a collapsed bridge of the nose. We discussed this last time. And other drugs, I mean, I've not seen much. I've seen 1 or 2 cases only with anti-TNF. And most of these drugs which are described in literature, sulfonamides and all, they're more of a cutaneous vasculitis rather than a systemic disease. Montelukast, in the past, they thought that it was one of the etiological reasons for a Church-Strauss presentation, but then later on they realized that because of chronic allergy, people were using more of this drug rather than the drug itself causing vasculitis. And my last slide, prevalence of ANCA positivity from infections and infection etiologies. So if you look at this series of infection, endocarditis, 47 patients, the overall ANCA positivity was almost about 43%. That's a big number of endocarditis patients who were ANCA positive. And of this, 50% was C ANCA. So beware, beware. That is what I would say. And the same way, some of the other series that reported with tuberculosis. There's one series from India also, 70 patients with tuberculosis, 21 were ANCA positive, of which 8 were C ANCA and 11 were P ANCA, and some were atypical. And a couple of them, if you see this line, PR3 was also positive. So be careful when you see. And chronic Hep B, Parvo, I already said ANCA positivity, EBV, CMV, everything can give rise to ANCA positivity. So this is just one. Now, other rare causes of emboli could be cholesterol emboli, hypercoagulable state, calciphylaxis. So remember all these rare conditions when you look at it. So these are some of the small vessel vasculitis mimics. Now, I did not cover large vessel vasculitis mimics because that in itself is a big thing, where you see stenosis, where you see aneurysms, where you see periaortic inflammation. There are a whole lot of differential diagnosis. So this I would advise you guys to read. This is a beautiful review. This has concentrated on a lot of vasculitis mimics. And if students want, I can post it in the DNB group and you guys can read it. Thank you very much. And I'll be happy to take any questions. Hello?
Any questions?
Yeah. I thought there's muted silence. I thought everybody had run away because I couldn't see who was there and who wasn't there.
Good evening, sir. Thank you for the class, sir. That was really informative. So I had one question on one of your patient who with that rhinocerebral aspergillosis. The fungal stains were negative, sir, but the biopsy did show fungal hyphae and then culture proved aspergillus.
Yeah.
So the fungal stain, was it, sir, the serum galactum, and then was that the investigation that was done? That was
so
negative?
basically what happens is, this is the other lesson you learn from vasculitis, in the fact that when you see reports, always look for reports from people whom you believe, because the problem is, as much as that there are not so well good trained physicians, there are also not so well trained pathologists, not so well trained radiologists. So actually it was there all along. It was just missed in the first laboratory. The second lab, when I asked them to restain the blocks, it was picked up.
Okay, sir. Thank you, sir.
So that's why if you see, when we re-looked at the CT scans, we picked up a few things. When we re-looked at the biopsy specimens, we picked up a few things. So, you just have to keep re-looking into it and keep discussing it again and again with radiologists and other allied specialties. That's the key. When you think something is not falling in place.
Yes, sir.
Any other questions? Anybody wants to add anything else? Any one of you have seen any unusual things like vasculitis? And if somebody has seen something, you can always share any other unusual causes other than what we have.
Sir, I have a question if it's okay.
Yeah,
Sorry.
yeah, sure. Yeah.
In terms of trial and response to treatment, how long would you, like in a case, how long do you think that, steroids aren't working, this isn't vasculitis? When does that thought come to your head?
Yeah. So generally, if it's a vasculitic manifestation of the disease, they respond very well to steroids, as you know. It's the granulomatous manifestation of the disease that are slow to respond. But still, when you look at vasculitis, they usually respond very well to steroids, like how you see it in lupus. So you actually, if you have given 60 milligrams of prednisolone for 2 weeks, you would expect some relief out of it or some benefit out of it. And especially ENT manifestations and all, even 40 milligrams of prednisolone, they report great benefit within a week or two. So I would, at least 3 weeks is my cutoff. It's an arbitrary cutoff. After that, I'll be worried. I mean, obviously, it could be a resistant disease, not that it can't be vasculitis always. It could be a resistant disease. But at the same time, I'll also start thinking, am I missing out something on the diagnosis?
Thank you, sir.
Anything else?
So would IgG4 present as a solitary retroorbital mass in stroke?
IgG can present as a solid retroorbital mass. I have 3 patients, but I haven't seen anyone as a stroke. But then don't forget that IgG can present as granulomatous pachymeningitis. So, IgG can present in various ways, but, always, it's not a disease that is known to spread contiguously. That is, if you have Wegener's can sit in your orbit and through the cribriform plate climb up and spread to the meninges. If you have other diseases, they can climb up. I've not seen an IgG4 that climbs up, or there is no contiguous spread that I have seen. I mean, I haven't seen a great deal of IgG4. I'm not an expert on that. But from whatever I have seen, I haven't come across as a stroke per se, unless it's a part of granulomatous meningitis. IgG4 meningitis, chronic meningitis.
Hello, sir.
Yeah.
Sir, while working up a case for suspected small vessel vasculitis, we often go for a skin biopsy. So many times in the report, they report it as leukocytoclastic vasculitis. That's it. But should we go for a punch biopsy is good enough, or an excision biopsy will be sufficient? They don't often comment on the medium vessel involvement, because as we know, medium vessel can also involve small vessel. So there's always this confusion. So what kind of biopsy would be adequate, and what exactly should we look for in the report that will make the report feel adequate? If there is no mention of medium vessel, whether we should again resend the report for a recheck or not, sir?
Yeah. So I think we discussed the importance of skin biopsy in the last class. I think last class probably we were not there, but I'll repeat it for the benefit of others. Of all the organ biopsies in vasculitis, the most useless biopsy is the skin, because the skin biopsy only tells you that it is vasculitis. It does not give you an etiology to the vasculitis. And when you do a skin biopsy, obviously leukocytoclastic vasculitis is whatever you report you get. It will not tell you the cause of leukocytoclastic vasculitis. Also, the only area where skin biopsy is useful is when you do immunofluorescence and you want to exclude Hinox-Schönlein purpura, HSP. Only then I will depend on the skin. But otherwise, if the lesions are classically vasculitic, I've hardly biopsied the skin. Many a times I get the patient with the skin biopsy already. What we were discussing last time was to very carefully examine all other systems and see whether we can get hold of another system to biopsy, because there you would get an etiological diagnosis.
Okay, sir. Okay, sir.
Any more questions? Anyone, please?
Hello, sir.
Yeah.
Sir, we have a case. She presented with macroscopic hematuria, sir. So literally, she is bleeding from her kidneys. So we did all investigations like ANA, ANCA, everything was negative. No constitutional symptoms, nothing. but the kidney biopsy has shown like class 2 lupus nephritis kind of pattern. But we reviewed it on our St. John's. The pathologist has told the same, but nothing suggestive of any kind of lupus. Like we were pushed to the wall and we have given cyclophosphamide. We had sent her, but we don't know what was the reason for her macroscopic hematuria. We can see literally a very red color urine, and the what could be the cause, sir? We couldn't find.
What is ANA complement? Any
Sir,
other features of lupus?
everything negative, sir. Normal compliments, ANA was negative, Midline was negative, anchor was negative.
So
Everything.
isn't it unusual? See, you have somebody who doesn't have any other features of lupus. You have somebody who's an ANA negative, but you still suspect lupus. And on you have that a macroscopic hematuria, which is extremely unusual, which means the kidney has bled basically. And finally, you have something like a class 2 lupus nephritis on biopsy. I mean, which class 2 lupus nephritis will bleed? It will not. I think there is something wrong in the diagnosis. Even if it was class 2, I wouldn't give her cyclophosphamide because cyclophosphamide is not indicated for class 2. What class 2 will only tell you is that there is some mild immune activation nephritis. That's all. So either she has not evolved into anything else, or over a period of time she will evolve, or you have to more carefully look for other manifestations. So in these cases, a CT angio would be helpful to look at the renal vasculature. Have you done a CT angio?
Oh no, sir.
Because you can get a pan-like presentation if you have had microaneurysms. Like how we discussed pan last class, you can have bleeding, you can have gross hematuria from that, and when you give cyclophosphamide, it works for pan as well. So I would do a CT angio and look at the kidneys. If there is nothing on that, then I would go for a cystoscopy and I would look into the bladder to see if there's anything that is causing gross bleeding. Because today, for whatever reason, the bleeding might have stopped, but tomorrow it is going to come back unless you've treated the cause.
CT-KB we have done, sir. It was also normal.
Yeah, so CT may be normal, but then you will need invasive things like, as I said, the angiogram part is important. And with all the specifications that we discussed last class for PAN, and then also to do a cystoscopy to look at the bladder. Because gross hematuria is unheard of in vasculitis, unless I've seen, it's not that I've not seen, single organ vasculitis, as I described last class. I had a lady with one kidney bleeding profusely and she only responded to nephrectomy. But then that is only after excluding all other cause. And like the guy who had renal cell carcinoma, they did an angiogram and they embolized a bleeding vessel in the kidney. So there are many things, other things that you have to look for rather than go for cyclophosphamide. I would be skeptical to give cyclophosphamide in.
And we had a reference from Hansen, like she is a case of MDR tuberculosis and she is on second line ATT. For 1 year, for 10 months, and for 2 months, like she started developing severe burnings in the both feet. So she went to NIMHANS. They did all those things, ANA, anchor, everything, and with the nerve biopsy. Nerve biopsy has shown some vasculitis. So they have referred to us, but sir, it is like there are no other features of any vasculitis.
And it's only a sensory neuropathy.
Yes, sir. And nerve conduction studies also showing like pure sensory axonal region, pure sensory neuropathy.
So it's a simple sensory neuropathy. Can it not be drug induced?
Yes, sir. We thought of that only because just nerve biopsy is showing like it was deviating. So
I'm surprised why they did a nerve biopsy for somebody who's on ATT.
I don't know, sir.
ATT is the commonest cause for neuropathy.
Yes, sir. But why that nerve biopsy has shown vasculitis is like.
See, that is the thing, no? That's why I said when you see, if you ask the pathologist, is this vasculitis? Majority of the times the answer is maybe there is a small amount of neutrophilic infiltrates in the vessel. You know, these sort of explanations are given and then they'll say probable vasculitis. So probable vasculitis is a dangerous diagnosis. So you can get a few just because you find some neutrophilic infiltrates in the vessel wall doesn't make it vasculitis. So that's why always beware when you find such. If you find fibrinoid necrosis, necrotizing vasculitis, then it's a different thing altogether. Otherwise, just be careful. And as we discussed just now, tuberculosis can be a cause of vasculitis. Although here, the neuropathy, I think, is drug induced.
Thank you, sir. Neutrophilic infiltration was there, sir.
Yeah. I wouldn't go by too much on those reports. Sometimes you should know what to take and what not to take from the report.
Yes, sir. We have discharged her with like drug-induced neuropathy.
Yes, true, very true.
Thank you, sir.
Sure.
Any more questions?
So going back to Dr. Shashikala's case that she presented from St. John's about the first patient with gross hematuria, could it possibly be post-immune presenting glomerulonephritis?
Then, if you are saying post-immune crescentic glomerulonephritis, you will see crescents. The moment you see crescent in kidney biopsy, then you know that it is vasculitis. There is no crescent here. They only said the histological appearance are more in keeping with a class 2 lupus nephritis. So just because it's post-immune, in fact, she said the immunofluorescence was more in keeping with a class 2 type, which means a little bit of immune deposition here and there. So I don't think it is post-immune crescentic glomerulonephritis, because in post-immune crescentic glomerulonephritis, you will find proper crescents.
Thank you, sir.
Thank you.
So,
We're done with questions?
yes, sir. Can we end it here?
Yeah.
Okay.
Brilliant.
Okay, sir.
Okay. Thank you,
Okay, sir.
everyone.
Thank you so much, sir. Thank you.
Thank you.